Thank you very much. It's a pleasure to be back here, and I look forward to the conclave as it unfolds over the rest of today. My wife and I always enjoy coming to Chennai and seeing old friends. I'm giving two lectures today, and I've chosen to concentrate on the two major areas of therapy in epilepsy: medical treatment, which I'll speak about this morning, and then surgical treatment that I'll speak about this afternoon. We're required now in the United States to always have a disclosure slide, and these are my disclosures. There's nothing that would compromise anything I'm going to say in this talk. So just a few general remarks about epilepsy first, because epilepsy is different from many of the other neurological diseases we deal with. It's a neurological disease that is both common and, generally speaking, treatable. It's a chronic disorder that is intermittent and not progressive. It occurs across the entire lifespan, with peaks in infancy on the one hand and among the elderly on the other. And in between those two extremes, it's almost equally likely at any age between. It's a common condition with no specific diagnostic test that can be highly stigmatizing. Oops. With the dark, I can't see. Can I just say next? So you'll change it because I can't. Or I can just hit here. Okay. That doesn't work. Let's see, this one. Epilepsy creates a huge burden, both for the individual patient as well as for the community. In the United States today, there are about 3 million people with epilepsy, and each year, roughly 200,000 new diagnoses are made. About half of these occur in children under the age of 15. 4% of white middle-aged Americans will have a seizure by age 20. 10% will have a seizure by age 80. And the incidence is twice as high in socioeconomically deprived areas. The cumulative incidence of epilepsy to the mid-70s is just over 3%, and the annual cost to the nation is over $15 billion a year. Epilepsy is a disorder made up of many aggregate parts, and these parts may vary from one individual to the next. In some, a specific etiology can be identified. Genetic background colors the picture, particularly in certain epilepsy syndromes. The nature of the seizure activity in terms of its characteristics varies considerably. Anti-seizure drugs, of which there are an increasing number, vary in efficacy and adverse effects. Some are much more specific for one kind of epilepsy than another. When seizures originate focally in particular, but also in some of the secondary generalized epilepsies, brain dysfunction and cognitive abilities may be affected. There are various environmental factors that may trigger seizures, and clearly, epilepsy, particularly occurring during a period of growth and development, may have significant effects on personality development and psychosocial adjustment. And of course, in some cases, there are associated neurological abnormalities. So the individual with epilepsy is a composite of all these things. It's not just straightforward in terms of having seizures, but the seizures and the underlying causes of the epilepsy affect many other things that will color that individual's life significantly. Now, I'm going to speak a bit about anti-epileptic drugs because I want to conclude later on with some comments about some of the difficulties we're facing now in terms of developing new ones. The critical questions are these. Between 1938, when Dilantin was introduced, and the end of last year, the critical questions are, with all the new anti-epileptic drugs, how many more patients have been controlled? How many patients have fewer side effects? And critically, do the newer drugs improve efficacy over older ones? And here I think is a complete list, unless I inadvertently omitted something, of all the epileptic drugs that are available today in the United States. So we have a lot of anti-epileptic drugs. What would make an ideal anti-epileptic drug? Well, there's several significant features. One, we would like a broad spectrum anti-epileptic drug that's effective against multiple, preferably all, seizure types. We'd like a drug that has no adverse effects or interactions with other drugs, a drug that's easy to administer and can be given by multiple different routes, one that is not teratogenic, so one needn't be concerned in a pregnant woman, inexpensive, not an inconsiderable consideration. Absorption is predictable, no or very low protein binding, linear kinetics, no active metabolites, no enzyme introduction, renal clearance, and a long half-life which would allow once daily dosing. Now, of course, there is no such thing as a perfectly ideal anti-epileptic drug that would meet all of these criteria, but certainly the development of newer anti-epileptic drugs has allowed us to have some that approach many of the criteria that I've listed in this slide. And if you look at the older drugs that were available in the 60s and 70s, they were characterized by those features that are listed in the left-hand column. And in contrast, many of the newer anti-epileptic drugs have many more desirable properties, even if none has all of the ones that I listed. So the first conclusion I want to draw is that new anti-epileptic drugs with more ideal pharmacokinetics have generally greatly improved the quality of life in patients with epilepsy by substantially increasing tolerability and consequently reducing drug failure because of adverse effects. The other thing that's been remarkable now is the number of molecular targets that these different drugs act at. In the early days, there were really only two mechanisms of action. When you think of phenytoin and its derivatives, later carbamazepine, phenobarbital. And that was they either act to reduce sodium influx and affect the firing rate of neurons, or they promoted GABA inhibition. Now, however, we have a range of drugs that have very different targets, including ones that act primarily at calcium channels, a number that are mixed. Interestingly enough, just as a parenthetic comment, even though valproate was introduced in 1978, we know a number of effects it has at a molecular level, but we really don't know which combination of these exert its principal anti-epileptic effect. GABA receptors, as I indicated, were the principal mechanism of phenobarbital and primidone, and more recently the benzodiazepines. There is now a drug that blocks the GABA transporter and one that inhibits GABA transaminase. We have a drug that in essence props the potassium channel open to facilitate inhibition, and we have one that acts at a very novel site, a synaptic vesicular protein, and that's levetiracetam. So these new molecular targets are of great interest. Some of them are frankly fortuitous. Others have been more related to the design or selection of the drug for development. So the SV2A target is a synaptic vesicle glycoprotein that facilitates vesicle fusion and is the mechanism whereby levetiracetam and brivaracetam act. The Kv7-CNQV target mediates an M current, which reduces repetitive firing and burst generation, which are, of course, both features of an epileptic neuron. And esogabine, quite new anti-epileptic drug, is an example of that. And then the alpha-2 delta subunits of the calcium channel are specific targets of gabapentin and pregabalin, and these affect the voltage-gated calcium current. Interestingly, and I don't know what the significance of this is, but when you look at these various new drugs that act on these particular targets, all of them act on presynaptic terminals to modulate transmitter release at synapses in one way or another. They don't work on, principally at least, do not work on the postsynaptic side. So let me just say a few more words about some of these newer drugs. Esogabine activates a specific potassium channel. It's a facilitator that underlies the M current. And it does this by, in a sense, propping the channel open so that more potassium comes in, the membrane is repolarized more rapidly, and it reduces repetitive firing, which is, of course, a characteristic of epileptic neurons. Lacosamide is a selective enhancement of voltage-gated sodium channel, but it works at a slow inactivation site, which means that it mainly affects neurons that are already depolarized or have been firing for long periods. And that, of course, is a characteristic of many seizures, particularly ones that are repetitive or that go on for a long period of time. That's a very desirable feature, and I think lacosamide is finding increased use, at least in part because of this. Levetiracetam, as I already said, binds to a synaptic vesicle protein. And what this probably does, although it's not known by any means for certain, it probably modulates the release of neurotransmitter to decrease excitability. And in experimental preparations, this has been shown to be most effective against neurons that are rapidly discharging. Parapamil is the first AMPA antagonist. It's a non-competitive AMPA antagonist. And rafinamide, its mechanism of action is uncertain, although it's hypothesized that it may stabilize sodium channels, particularly in the inactivated state, which means that they don't open as readily, let more sodium in, and increase the excitability of the neuron. So the second conclusion I would leave with you is that newer anti-epileptic drugs have a greatly increased range of molecular targets that theoretically, at least, we don't know yet whether this is true or not, theoretically increasing the scope of anti-epileptic effects. And I'll come back to that theme later on. So let me talk now about treatment of some specific circumstances. First of all, what do you do when a patient presents with a first seizure? There's no question that in several very large epidemiological studies, if you treat a first unprovoked seizure, you will reduce the recurrence rate by about 50%. However, what is important is that those same epidemiological studies have shown that even though that may happen half the time, there is no difference in the long-term outcome in patients being treated and those that were not treated. The 2-year remission rates, for example, are the same in the two groups. Anti-epileptic drug therapy reduces the risk of seizure recurrence, but it does not alter the underlying disorder or thus change long-term prognosis. And we are frustrated, I think, by the fact that none of the anti-epileptic drugs, even though they may affect recurrence, do not prevent the development of epilepsy. So let me give some broad guidelines about treatment of epilepsy. There's no question that anti-epileptic drugs control seizures in the majority of patients with epilepsy. But there are some important buts about that statement. The majority of epilepsy patients become seizure-free within a few years following initiation of treatment, but long-term treatment with anti-epileptic drugs is associated with significant morbidity. This is more true of the older anti-epileptic drugs than the newer ones, but it is still true of the newer ones, which are not side effect free. A third but is that seizure control is less likely to be achieved in patients with remote symptomatic, that is, there's a presumed or known cause for the epilepsy, or patients who have epilepsy due to a cerebral lesion, specific epilepsy syndromes such as the epileptic encephalopathies that are particularly common in childhood, patients who are treated who already have a long duration of epilepsy, and at least in adults, those who have persistently abnormal EEGs. All of those circumstances increase the likelihood that seizure control will be less than optimal and certainly less likely full control to be achieved. Nonetheless, at the same time, anti-epileptic drugs do control seizures in the majority of patients with epilepsy, but the details of how this happens or what the details of the outcome is do vary. Nearly 40% become seizure-free within 6 months. Another 20+% or so become seizure-free after 6 months. About 16% show alternating periods of being seizure-free and having seizure recurrences, and those periods may vary from months to several years. At least 25% of patients with epilepsy never become seizure-free. And in general, patients needing 2 or more drugs and trials of different anti-epileptic drug regimens to achieve optimal control and minimize adverse effects, that group has a particularly low probability of becoming seizure-free. In children, in particular, 60 to 75% who have been seizure-free for 2 to 4 years, the studies vary in the duration of follow-up, remain seizure-free after anti-epileptic drugs are withdrawn. And so that's an important thing to note in children who meet the criteria for that. However, the other side of that coin is that 70 to 80% of patients with persistent seizures, that is those that we consider drug resistant because they don't respond to repeated trials of different anti-epileptic drugs, retain their status as intractable for long periods of time, and probably in many indefinitely. So my third conclusion is that in my view, there is no compelling evidence to date that suggests that the prognosis for complete control of seizures has improved in the last 25 years, despite a number of new anti-epileptic drugs, many of which have very better pharmacokinetic and pharmacodynamic properties that make them more tolerable to patients, the regimens easier to manage, and improve treatment broadly. So, can't see. Oh, thank you very much. Thank you. So an important question related to that third conclusion is, why has it been so difficult to improve the effectiveness of anti-epileptic drugs in controlling seizures and reducing the number of patients with drug-resistant seizures? That's the fundamental question that we face in many patients. Why am I able to treat this particular patient effectively, and this one I keep trying different drugs and using them properly and so on, and seem to make little headway? Well, one of the problems, I think, is in the pivotal trials. That is, those initial trials that are conducted to demonstrate that the drug is safe and to get some perspective on its efficacy. And the pivotal trials are required by the Food and Drug Administration in the United States, and I'm sure there are similar groups in other countries as well, that determine whether or not the pivotal trials are sufficiently persuasive that they will approve marketing of the drug. And there's some reasons that this is not an ideal situation. First of all, the new anti-epileptic drugs are almost always approved only for adjunctive therapy. And you know that if you have a drug that can only be used in combination with another drug, it's because the patient's seizures are continuing, and that is a group that from day one of a trial is a harder group to deal with than a different patient group that might have a more favorable outcome. And this also relates to the nature of the trials that the FDA in the United States requires for drug approval. That is, the standard trial is an add-on where a new drug is added to a standard anti-epileptic drug in patients with frequent and uncontrolled seizures. So again, you have a hardcore group that's being treated with a new drug. It's an uphill battle, in other words. What these trials will do is to prove that the new drug is superior to a placebo, but they provide no meaningful information about the relative efficacy of a new drug compared to other available anti-epileptic drugs. And there's certainly no information at the time a drug is approved for marketing about its efficacy as monotherapy. And finally, I think it's unfortunate that this group of patients who are really quite refractory, tough, hardcore group, is unfortunate because while it is representative of an important segment of the population with epilepsy, it is by no means representative of the epilepsy population as a whole. So why are seizures so intractable in patients who don't come under control? And I think that there is a growing body of evidence that defines at least several reasons for this. Increasingly, we recognize structural alterations in the brain, ones that may require microscopic examination of tissue to determine, that won't be seen necessarily on MRI scans. And we're increasingly aware of what has heretofore been unrecognized genetic abnormalities, and in one at least large-scale recent trial, these have been genomic microdeletions, as well as epigenetic variants that affect neuronal and network excitability. Many of the drugs have more than one action. Valproate, for example, has multiple modes of action. We don't, in fact, know for certain what its principal mode of anti-epileptic effect is. So, at the same time, excitability in the brain is obviously a critical element for normal brain function. And not surprisingly, there are many, many different mechanisms that control neuronal excitability, that break it in very controlled ways under very specific circumstances, accelerate it depending upon the type of function in other circumstances. And it's not surprising that given this huge range of mechanisms involved in regulating neuronal excitability within the brain, makes it difficult to find a drug that will be ideal in terms of cutting across the population of mechanisms. A frequent cause, I think, is that the drugs simply don't reach their targets for one reason or another. And lastly, at the present time, despite many workshops and lots of discussion, there really is a relative, I would say, absence of strategies for rational and treatable or testable pharmacotherapy using multiple drugs. So we have good, reasonable strategies for testing single drugs, although there are some problems with those, as I indicated a few moments ago. But we really have a significant absence of strategies for testing rational polytherapy. Clearly, drug resistance varies across the different types of seizure. This is an old slide now, a classic study of Salampa many years ago, who looked at seizure types principally in children and young adults, and looked at the percentage of patients who were, as he defined it, drug resistant. And not surprisingly, you could probably make this list up even without seeing this. Those patients who have idiopathic seizures, who are neurologically normal and so on, do very well with a relatively low rate of drug resistance, whereas those that are secondarily generalized, who are associated with evidence of neurological dysfunction or abnormalities of the brain, constitute a significant percentage of patients who are drug resistant. I'm going to skip this because I'm going to talk about this later in my second talk. But I do want to indicate some of the newer studies that are defining previously unrecognized structural alterations in the brains of patients with epilepsy. One is the growing recognition of what has been called by Harry Vinters, who's the head of neuropathology at UCLA, microdysgenesis. In addition, microheterotopias are increasingly recognized, as are microscopic areas of abnormal lamination. Grossly, the brain appears normal. If you scan microscopic sections of large areas, they appear relatively normal, but very careful analysis of critical brain areas known to be important in epilepsy are increasingly revealing these microscopic areas of structural abnormalities. There are a number of inflammatory markers that are increased with chronic anti-epileptic drug resistance. What the relationship between the two of those is unclear, but certainly the activated glia that are seen and the inflammatory markers suggest that there are processes going on that may contribute to drug resistance. One of the most important factors, I believe, is what I call maladaptive rewiring. And this is synaptic reorganization that occurs in a chronic epileptic focus, where axons develop connections in abnormal ways to different parts of a neuron, to different targets, and so on. And this kind of synaptic reorganization, which has been best demonstrated in the hippocampus of the brain in patients with temporal lobe epilepsy, I think is a significant contributor to drug resistance. Among the manifestations of this are widespread axonal sprouting and loss of both principal neurons and modulatory neurons, such as in the hippocampus, for example, mossy cells and calretinin-containing interneurons, which are both important in hippocampal inhibition. Mutations in tuberin have been recently described, even in the absence of any overt pathological changes that one might anticipate. Areas of gliosis may contribute to abnormal regulation of the extracellular microenvironment, and a number of subregional and other hippocampal abnormalities are increasingly being identified by very high field MRI. And in addition, abnormalities of cortical thickness are being reported in a number of patients now with intractable seizures. And particularly in this one study I cite here, which I included because I think it's interesting, seem to be overrepresented in a group of patients who's had either brain biopsy or who had died and they had the whole brain with postictal psychosis. So what about genetic factors? We know now, and in fact some of the cases that were discussed yesterday are that there are a number of mutations that cause channelopathies, that is, alteration in ion channel function, and these are particularly characteristic of the inherited idiopathic epilepsies. But beyond channelopathies, in the last several years, there have been a number of other molecular abnormalities that are being described that, theoretically at least, would have important effects on neuronal excitability, and as well as organization of brain circuits. And I'm not going to go into these in detail, but clearly the list of these kinds of molecular targets and regulators that are important in controlling neuronal excitability are undoubtedly important in epilepsy as they are in normal brain function. And we don't have ways of measuring this at the present time. We don't have anti-epileptic drugs that target some of these new genetic targets that are being identified. And how important they are in certain types of epilepsy versus other types is completely unknown. But I think one point I want to leave is that increasingly probably there are individual variations in genetic control of excitability that may be quite individualized in small groups of patients, and therefore sweeping statements about excitability related to occurrence of seizures, development of epilepsy, or finding drugs that will work across all of these new mechanisms that are being described probably is a very difficult challenge. The most recent study of this that is beginning to appear is the very large genetic phenotype correlation studies that are being done on a large scale in the United States, headed by Dan Lowenstein at UCSF. And what they are reporting now is that the most common abnormality that they're seeing in looking at the entire genome, and I think it's 5,000 plus patients with epilepsy, are single abnormalities in phenocopy, so that there are very, very tiny changes that may, in these patients, have more widespread effects. So novel mechanisms are giving insight into pathogenesis and may guide development of new therapies, but I will qualify that, as you may have inferred from my previous remarks, is what this is doing is just increasing the complexity and making it, I think, more difficult to understand the role and importance of individual factors in a particular patient, or which ones may be important to try to develop drugs to target. And certainly some of these genetic abnormalities, until we can manipulate portions of the genome more than we can do today, are, in a sense, untouchable. A final point I want to make that, again, is just another illustration of how complex the situation is becoming, is that there may be a receptor or channel in which mutations can cause either a benign change of either no significance, or ones in the case of seizures that are easily controlled with anti-epileptic drugs, or severe effects. And these kind of potassium channels, the KCNQ channels, are the principal mutation that are seen in benign family neonatal seizures, as I'm sure you know. And it's this channel that is targeted by the new drug isagabine. But the same channel, different mutation, but the same channel, can also cause a severe neonatal epileptic encephalopathy that is similar to Ohtahara's syndrome and the early myoclonic encephalopathy. The details of what these few slides I've shown you now are not important. What is important, I think, to take away is that the complexity of control of brain excitability is far, far more complicated than we had anticipated. And it is likely that the complexity of mechanisms of abnormal excitability in patients with epilepsy are much more complex than we had originally thought. And it's therefore not surprising, I think, that a new drug may have a relatively small, if any, impact on this large group of patients with drug-resistant epilepsy. I'm going to, in the interest of time, skip over a few slides. Just to amplify what I was talking about a moment ago in terms of the complexity of genetic contributions to control of excitability, we are only really beginning to identify these susceptibility genes. In rare monogenic focal epilepsies, fewer than 20% of the families have their molecular basis of their epilepsy identified. And more common focal epilepsy syndromes, for example, benign Rolandic epilepsy, benign occipital epilepsy, have very complex inheritance patterns, and little is understood about the genetic and acquired determinants in this group of patients. Last comment in terms of genetics that I want to make is, I think, a very exciting area, and I'm not going to spend much time on it, but in that is the whole role of epigenetics in brain diseases, and epilepsy is no exception to that being the case. Epigenetics was not even recognized as a significant factor in disease until fairly recently, and now we're getting novel insights into their role in, one, the susceptibility of some patients to epilepsy, and also the onset and progression of their disorder. And a number of mechanisms, which I'm not going to go into, have been identified that are epigenetic in nature and presumably play a role in the susceptibility to epilepsy in certain patients. So let me come back to treatment now. What can we do to improve it? The Epilepsy Phenome Genome Project that I referred to earlier, that Dr. Dan Lowenstein is heading, may create at least a few identifiable novel targets for drug development that can then guide laboratories and pharmaceutical companies in terms of new therapeutic strategies. This would be particularly helpful, of course, in patients who have intractable seizures that are not responsive to current anti-epileptic drugs. I think we will get a substantial amount of new information, and I only hope that it can be interpreted and sorted out, sifted out in ways that will guide future research. But there are about 4,000 epilepsy genomes that have been identified now, and presumably out of this will come some additional targets for novel therapies. And the Human Epilepsy Project is another exciting ongoing research activity in which there are 500 patients with new onset epilepsy that are being followed with detailed correlation of clinical, genetic, metabolomics, imaging, and EEG correlates of outcome. And that should, over the next 10 years or so, provide additional information. One of the areas that remains a challenge, despite it having been a subject of discussion for at least 50 years probably, is polytherapy. That is, rational, targeted drug combinations. Very few of these polytherapy regimens have been tested in controlled clinical trials, and particularly in patients with structurally normal brains. And we have really very little information on which to guide polytherapy. We systematically usually try to use two drugs that have different mechanisms of action. But we have very little information about which ones might work and which regimens might be appropriate in patients with uncontrolled seizures. One of the things that I would suggest is that, how do I go back here? Is I would like to see some controlled clinical trials designed around drugs that act on mechanisms that we know now are important in some aspects of epilepsy. So for example, we have very good information now about the currents and targets that are important in both interictal discharges, the spikes and sharp waves we see on the EEG, as well as the changes that occur during seizures. And we now have drugs that work on a number of these mechanisms. And I would like to see a controlled trial developed in which drugs acting at ionic currents and targets that we know are involved in specific aspects of epilepsy in terms of EEG phenomena, and to see if that would provide any benefit in terms of identifying combinations that are more effective than the rather vague ways we look at polytherapy regimens today. And the last thing I want to mention is that the pharmaceutical industry is facing a crisis, and we, in turn, as physicians caring for patients with epilepsy, are going to be caught up in that crisis because there are fewer and fewer companies that are interested in developing anti-epileptic drugs. And why is that? Well, here it is. In 1969, when I'm coming to the end. In 1969, when I graduated from medical school, the drugs on the left were the principal ones that we used. By far and away, the most widely used drug was Dilantin, with phenobarbital being the second most common. In 1975, when I finished my epilepsy fellowship, Tegretol had entered the picture and was beginning to encroach on Dilantin, although for a number of years, and some of you may be old enough to remember this, there was very great concern about Tegretol causing leukopenia. And it was a long time before, frankly, we recognized that there was a very common, totally benign drop in white count early after starting Tegretol. And the best thing to do is simply not to look at the blood count during that time. But that delayed the wider incorporation of Tegretol into anti-epileptic drug regimens. Oops, now this isn't moving. The button doesn't work. Yeah, fixed, okay, thank you. In 2011, this was what the pie looked like. I don't know whether the size of those pie slices are accurate, but this does reflect the number of anti-epileptic drugs, and presumably the pie is divided up in more ways. But the size of the pie is not growing, at least in the United States. And as a result, in recent years, pharmaceutical companies have wanted drugs that have more than one clinical use. And the group that they have been most interested in is psychiatry. Psychiatric patients are a much larger population than the population of epilepsy. And as I'm sure you know, the number of anti-epileptic drugs now are being widely used in psychiatry and in other neurological disorders. I suspect in the United States as much topiramate is being used for headache, migraine headache, or close to it as being used for seizures these days. Drugs that have an anxiolytic benefit, those are real winners because the number of patients with anxiety who get treated with these drugs is far, far greater than the number of patients with epilepsy. So pharmaceutical companies have lost interest, at least in the United States, have lost interest in developing anti-epileptic drugs because the market for an individual company has shifted. The pie has not grown in size, the number of drugs have, and the proportion of the market that any single pharmaceutical company has is much less. I think, on the other hand, this is a great time for what is happening in the world of genetics. I told you about all the new targets that are being identified and so on. These are probably going to be in small numbers of patients. And this is an ideal situation for small laboratories and academic medical centers to partner with a small commercial entity around a particular group of patients. And I think that we're going to see more of that as this goes on, but we just can't count on the major pharmaceutical companies as we once did. I'm going to end there in the interests of time, but I want to conclude with this slide, which I like very much. I got it from Jackie French, a very good epilepsy doctor, clinical pharmacologist in New York now. When we go to the clinic to see patients with epilepsy, this is what we see. They may be old or young, fat or thin, and so on. But their brains and EEG look very similar to us at the present time, or at least their response to drugs looks very similar. The whole area of pharmacotherapeutics is undoubtedly going to change this over the next decade or two. So that when we treat a patient, we will be able to use their genetic makeup advantageously to decide which drugs are most likely to be effective. And this is already happening in a few instances, not in anti-epileptic drugs to my knowledge, except in a few instances like people with carbamazepine who are in Asia who have an abnormal or a different pathway for metabolism. We do test susceptible populations now for that. But I think increasingly our patients will look like this, that there will be groups of patients that use one type of drug because of their unique epileptic mechanisms, and others that use different ones, and that we will tailor novel anti-epileptic drugs to the genetic makeup of the patient and hopefully have more therapeutic impact by doing that. Thank you very much.